Good afternoon, everyone. On behalf of the American Association for Cancer Research, it is my pleasure to welcome you to the special policy briefing to unveil the AACR Cancer Progress Report 2022. We have many people here in person in the audience and also 455 people on the line, which is very exciting. My name is March Foti, and I have the honor and privilege of serving as the Chief Executive Officer of AACR. AACR is the world's largest and first organization dedicated to advancing cancer research and its mission to prevent and cure all cancers. Over the years, AACR and its more than 52,000 members from the United States and 129 other countries and territories have been at the forefront of every major breakthrough against cancer. We marshal the full spectrum of expertise in cancer research and patient care to identify the top scientific priorities, convene conferences and educational workshops, publish 10 high-impact peer-reviewed scientific journals, and produce a magazine for cancer survivors, their caregivers, and dedicated patient advocates. Also, AACR communicates on a regular basis with policymakers and the public about the value of cancer research in saving lives from cancer, and it advocates for increased, sustained federal investments for cancer research, including laboratory science, translational and clinical research for patient benefit that includes early detection, interception, and cancer prevention. And that is why we are here today in our nation's capital. A cornerstone of AACR's communications to Congress and the public is our annual Cancer Progress Report, and we are extraordinarily proud to share with you today the 12th edition of this definitive publication that highlights recent advances against various cancers, including the approval of novel therapeutics that are helping patients today. It's wonderful to have our speakers here. And I also wanted to acknowledge specifically Dr. Anna Barker, who is here today. Anna led the Cancer Progress Report very early on. She was the head of this Science Policy and Legislative Committee and was instrumental in recommending that we write such a report. And here we are 12 years later. The report also features the personal stories of courageous patients who had benefited from innovative, recently approved anti-cancer therapeutics, and includes a call to action for policymakers to bring life-saving cures to millions of people who have received a diagnosis of cancer. This year's report underscores how cancer research, largely supported by federal investments in the NIH and NCI, continue to save, extend, and improve the lives of patients with cancer. I would add that it's exciting to note that already today we received a lot of press attention on this report. It has already hit the news, specifically ABC's Good Morning America and NBC News. So it underscores how important this information is to the public. So now, please turn your attention to the screen for a video highlighting some of the key points in the report.
Our son Tyler, our middle son, was diagnosed with a brain tumor in April of 2018.
The mass starts in his right thalamus and then expands with roots down into a lot of parts of his brain, which makes this tumor inoperable.
In October, I had a bump on top of my head. On January the 5th, he took a biopsy of it, said it was fast aggressive melanoma cancer.
I have stage 4 metastatic cervical cancer. Within a year, it came back a third time and it metastasized into my lymphatic system as well as some lung nodules that they were concerned about.
I met with the oncologist. The biopsy confirmed that was not Hodgkin's lymphoma.
VHL actually can cause both benign and cancerous tumors in various parts of the body. You name it, I've probably had it.
When I started my life in science, chemotherapy and radiation therapy were really the only armament for cancer medicine. We have now a revolution in immune therapies. And when you put that together with the combination of targeted therapies, chemo and radiation therapy, we now have patients that would have died within 2 years of a diagnosis, living 15, 20, 25, 30 years, essentially cured of their malignancies.
I don't know how my story will end, but in no chapter will it say that I ever gave up.
I had benign and cancerous tumors in my pancreas and kidneys. I actually also had a tumor on my cerebellum. About 8 months after having that Whipple procedure, I had to go back in for brain surgery.
The brain cancer was slow growing, and so we waited and we watched it over a year. Then it started to grow faster. And we knew that we didn't want his last days or months to be spent in the hospital on chemo treatment if this tumor was going to take his life. We wanted him to live it up, live every minute, every moment.
The new therapeutic approaches that we're successfully seeing in the clinic, those advances stem from basic science discoveries 20 or 30 years ago. Sustained funding has brought those ideas and approaches along to the clinic, where they're now FDA-approved standard of care medicines.
Science is amazing. They came out with inhibitors to target his exact mutation. We've been on the treatment now for over 2.5 years with a stable tumor.
There was a clinical trial of belzutifan. I was one of the lucky ones. It's 3 pills that I take. It's a once-a-day thing, pretty simple. Mentally, physically, I am greater now probably than I ever have been. This drug to me has just allowed me to sit back, relax, and really enjoy every moment.
I got the CAR T-cell therapy May 31st. I think that I'm feeling better.
From March the 4th of 2020, I still have no cancer. I've done scans every 12 weeks.
Being in a clinical trial was very eye-opening. I was given 15 months in November of 2018, and we are now in 2022.
There's still a lot of biology we don't understand that requires new investments while we maintain investments in the translational pipeline from the discoveries of 10, 15, 20 years ago.
Cancer researchers, keep doing what you're doing. Keep looking for new medicines to cure cancer. Keep up the good work.
I would say to members of Congress, I believe wholeheartedly, maybe not in my lifetime, but I hope in my niece and nephews, cancer isn't thinking, when am I gonna die?
There's a lot of others out there like me that need a real chance at life, and a drug like this is just life-changing. So if we could fund as much research as possible, all that's gonna give us more time with our loved ones.
And it's not going to happen unless help is given to these brilliant people out here that are sitting in labs, researching day in and day out to find ways to cure someone like me.
I feel that more funding needs to go towards childhood cancer and other cancer to find cures. We need more funding, more trials, more studies so that we can start curing these cancers.
Congressmen, Congresswomen, you need to fund this. You need to keep it up. You need to keep going with this. It's saving lives through these trials.
Thank you so much for your kind attention to that inspiring video. I would like to recognize the cancer survivors and their loved ones who are featured in the report, and also who are with us in the audience. Alex Gonzalez and his wife Raquel are joining us today, in addition to Johnny Borgstrom and his wife Deborah and granddaughter Cheyenne, and Alexandra Vitale and her partner Shelby Smith. We will be hearing from Johnny and Alexandra in a moment. Jennifer Myers and her husband Dave are watching live from home. Jen, we thank you for your support and participation and are thinking about you today. We also have special guests watching from California. I'd like to recognize Tyler Richards, who at 9 months old began suffering with the symptoms of cancer. Thanks to the loving and fierce determination of his parents, Katie and Ronnie, and the research that has led to a new clinical trial, Tyler has just started his first grade. Tyler, we are so proud of you and are sending you our best wishes all the way from Washington, D.C. to California. Tyler's mom, Katie, made the point about the power of community and how Tyler's friends and loved ones, including other children affected by cancer, have rallied around each other and found personal strength in that collaboration. It is that support as well as community that is so vital, and we thank you for sharing your story with us today. The strength of community, advocacy, and hope permeates the survivor stories in this report. The report also includes features of members of Congress, Representative Brian Fitzpatrick and Nikema Williams, who witnessed their loved ones' own struggles with cancer. Congressman Brian Fitzpatrick's brother Mike previously served in the same seat in Congress and was featured in our 2013 Cancer Progress Report, detailing his successful battle at the time against colon cancer. Sadly, in 2020, Mike Fitzpatrick lost his subsequent battle against a second cancer, melanoma. As Congressman Brian Fitzpatrick stated in the 2022 report, his fierce determination to make a difference against this terrible disease that affects so many has fueled his work in Congress, where he now co-chairs the House Cancer Caucus and advocates for additional funding for cancer research and prevention from the NIH, the NCI, and the Centers for Disease Control and Prevention. Congresswoman Nikema Williams talks in the report about how her mother's battle with colorectal cancer inspires her work today in Congress. She represents the 5th District of Georgia in the seat formerly held by esteemed John Lewis, who himself passed away after a courageous battle against pancreatic cancer. Congresswoman Williams is a strong supporter of federal investments in cancer research, increasing cancer screenings, and reducing cancer disparities, and we are thrilled that she shared the following powerful message with us. Please watch the video.
Good afternoon, everyone. I'm Congresswoman Nikema Williams, and I proudly represent Georgia's 5th Congressional District. While I'm not able to join today's Cancer Progress Report launch in person, I'll always be a champion for cancer research. Making progress to end cancer means more birthdays, more Christmases, more graduations, and everyday moments for families everywhere. Y'all, I know the pain of moments stolen by cancer. When my mama was just 46 years old, she was diagnosed with young onset colorectal cancer. One of the most painful parts of being a caregiver was fighting the insurance companies as they tried to deny my mama the coverage she needed. She died at the age of 51, and I learned a hard truth. Healthcare in America is not a human right, yet. We have 2 healthcare systems in this country, one for people who can afford preventative services and quality treatment, and one for everyone else. We must demand better. Black Americans have the highest death rate and shortest survival of any racial and ethnic group for most cancers. Even taking a step back from cancer, Black communities face the worst health outcomes and disparities across the board. I'm working in Congress to fix the failures of our healthcare system that got us to this point. But there's also a lot that we have to learn. We need methods for even earlier cancer detection. We need advanced treatment options. We need to learn more about preventing cancer in the first place. Investing in funding for research helps us get there. And I fully support President Biden's cancer moonshot so that we can end the suffering that cancer inflicts on millions of Americans every year. Together, I know that we can make this a reality. To the physicians and researchers, thank you for doing some of the most important work to fight cancer. Thank you for caring for our loved ones and making groundbreaking innovations to improve cancer detection, treatment, and prevention. I'll keep fighting to make sure that you have the resources to keep us moving much closer to a cure. And to the courageous cancer survivors, thank you. Thank you for raising your voices and sharing your stories. I believe that our stories are the most powerful tool that we have. And in the face of an enormous challenge, you're using your story to help others. Your bravery is an inspiration and reminds me why this work is so important. For more hugs, more smiles, more celebrations, for more birthdays, progress is well within reach, y'all, in the fight against cancer. You can count on me as a partner every step of the way.
Please join me in thanking Congresswoman Williams for that wonderful video. The passionate stories that Representatives Fitzpatrick and Williams have shared really underscore the importance of bipartisan commitment on Capitol Hill for medical research and cancer science and medicine. And the entire cancer research advocacy community is enormously thankful for their support. In fact, Congress has delivered 7 consecutive years of robust funding increases for the NIH and the NCI, and more specifically, after a number of years of flat funding, the NIH budget has grown by $14.9 billion, or 49%, since fiscal year 2015. And just last week, AACR led the medical research advocacy community at the 10th Annual Rally for Medical Research Hill Day to encourage Congress to continue this momentum and make medical research a national priority in fiscal year 2023. We are thrilled that more than 350 organizations and institutions were part of this initiative, representing millions of individuals, to raise awareness about the critical need for continued investment in NIH to improve health, spur progress, inspire hope, and save lives. Therefore, today we urge Congress to provide another year of robust funding for NIH, the kind of research that we heard about in these videos, and to complete its work on the fiscal year 2023 as soon as possible for the benefit of public health, as well as advances against cancer. By providing this funding, Congress will continue to help transform cancer care, reduce mortality, support cancer survivors and their caregivers, such as those in the audience today, spur economic growth, which is very important, and maintain the United States' position as the global leader in science and medical research. It is now my great honor to introduce our esteemed president of AACR, Dr. Lisa Cousins. Dr. Cousins is Associate Director for Basic Research at the Knight Cancer Institute at Oregon Health and Science University, where she is Professor and Chair of the Cell, Developmental, and Cancer Biology Department, as well as the Hildegard Lamfrom Endowed Chair in Basic Research. She was elected a fellow some years ago, fellow of the AACR Academy for her spectacular research. Dr. Cousins is an internationally renowned cancer biologist and translational researcher who is expert in the role of chronic inflammation in cancer, the tumor microenvironment, imaging, and the functions of innate immune cells in neoplastic progression. We want to thank her for her expertise, her leadership, and support in the development of this important report. The 2022 Steering Committee and Advisory Committee, and everyone on the staff, especially Drs. Raj Sengupta, Kaleem Zaidi, and Patrick Williams, who contributed their extensive knowledge of the literature and of science to the writing of this report. We are so proud to have Dr. Cousins as our president this year. Please welcome Dr. Cousins to the podium.
Thank you so much, Marge. Good afternoon, everyone, and thank you for joining us for the unveiling of the AACR Cancer Progress Report 2022. This 12th edition of the annual AACR Cancer Report continues the tradition of raising awareness among policymakers and the American public of the importance of medical research and policy in saving lives from cancer, and I am delighted to share with you some of the highlights of this year's report. I will also touch upon some of the ongoing challenges in cancer research and patient care. As Marge underscored in her remarks, much of the progress made against cancer has been supported by federal investments from the NIH, the NCI, the FDA, and the CDC. This progress is reflected by the steady decline in the overall cancer death rate in the United States, that we have seen over the past 3 decades. This decline has accounted for 3.5 million cancer deaths avoided between 1991 and 2019. That's remarkable. Advances against cancer are also illustrated by the fact that as of January of this year, the number of cancer survivors living in the United States exceeds a record 18 million individuals. Over the past 2 decades, we have made rapid progress in our ability to decode the biological complexities of cancer. Federally funded research in cancer genomics, including ambitious large-scale initiatives such as the Cancer Genome Atlas, have fueled a revolution in our understanding of cancer by identifying genetic errors that drive cancer development. In parallel, scientific breakthroughs in the field of immunology, coupled with technological innovations, have allowed us to harness and unleash the power of the immune system to attack and destroy cancer. The combined result is a major shift from a one-size-fits-all approach in cancer treatment to a more personalized one that includes molecularly targeted therapeutics and immunotherapeutics, which are yielding remarkable results for many patients. The innovative new therapeutics highlighted in this year's report and in the previous 11 editions reflect one tangible measure of progress against cancer and underscore the transformative impact of federal investments in medical research, which are providing life-saving treatment options for countless patients. Between August 1st, 2021 and July 31st, 2022, the period covered by this year's report, the FDA has approved 8 new therapeutics for treating patients with various types of cancer, 2 new diagnostic imaging agents, as well as having expanded the use of 10 previously approved therapeutics to treat additional types of cancer. Selected examples of these exciting new discoveries include treatments of patients with von Hippel-Lindau disease, a rare genetic disorder that predisposes individuals to cancers or benign tumors in various parts of the body, as experienced by Alexandra Vitale, from whom you will hear later this morning. Treatments for patients with chronic myelogenous leukemia who have developed resistance to the available molecularly targeted therapeutics. Treatments for patients with rare forms of cancer, such as uveal melanoma, a type of cancer in adults for which there was no standard of care treatment previously available. And treatments for adults and pediatric patients with any solid tumor that share a certain genetic characteristic. This newly approved treatment with a combination of 2 molecularly targeted therapeutics is already helping Tyler Richards, a 6-year-old with rare form of brain cancer. Tyler is just beginning 1st grade, and his remarkable journey is featured in this year's report. Among the newly FDA-approved immunotherapeutics covered in the report is the combination of nivolumab and relatlimab, which was approved for treating patients with metastatic melanoma. This combination of 2 immune checkpoint inhibitors, classes of immune therapeutics that function by releasing the brakes on our immune system and unleashing its power against cancer. It is important to note that relatlimab is the first immune checkpoint inhibitor approved against a novel target in 8 years. One of the most powerful ways to convey the magnitude of a scientific advancement is through the journey of those who directly benefit from it. I'm delighted that we will hear in a few moments from someone who benefited from the nivo-relatlimab combination, Johnny Borgstrom. Johnny, who graciously shared his journey for the report, has had no evidence of disease for over 2 years after receiving the combination treatment. It's wonderful. As we look to the future, we are excited to learn about the scientific breakthroughs and technological innovations that will stem from federal commitments to ambitious initiatives such as the Human Tumor Atlas and Reignited Cancer Moonshot. Outlines or outcomes of these initiatives will have far-reaching impact on saving and improving lives. Beyond developing new and effective anti-cancer therapeutics, Researchers are actively working on innovative approaches to detect cancer at the earliest possible stage when it is easier to treat successfully. Liquid biopsies are one such technology. Liquid biopsy refers to the collection and analysis of fluids from our bodies, such as blood, cerebrospinal fluid, or urine. This technology could have a major impact not only on early detection of cancer, but also on other aspects of clinical care, including monitoring of patients with cancer for response or resistance to therapy. While there are still many questions to be answered and big barriers to overcome, the use of liquid biopsy, particularly for early detection of multiple cancer types, simultaneously holds enormous progress for accelerating our progress against cancer. Another area of rapid progress is the use of artificial intelligence-powered methods for early detection in the diagnosis of cancer. Indeed, this year's report highlights 2 examples of FDA-approved software systems that are aiding clinicians in accurately and expeditiously detecting and diagnosing cancer. Even though we have made many advances, much more work is yet to be done. For example, it is estimated that more than 4 out of 10 cancer cases diagnosed among U.S. adults are attributable to potentially preventable causes, such as smoking, obesity, physical inactivity, alcohol consumption, and infection by pathogens. The success of smoking cessation policies in reducing smoking rates among American adults from more than 37% in the 1970s to less than 13% in the 2020s provides a blueprint to develop effective public awareness campaigns and regulatory policies to circumvent and navigate the impact of other risk factors on cancer incidence rates. Unfortunately, the current epidemic of electronic cigarette use among American youths has halted the progress against nicotine addiction and tobacco use, while the long-term health effects still remain unknown. Among the public health challenges posed by preventable causes of cancer, the rising prevalence of obesity is one that we must address urgently. Being overweight or obese as an adult increases a person's risk for many types of cancer, so it is extremely concerning that 40% of U.S. adults and 20% of U.S. children are obese. It is imperative that we work better to communicate our current knowledge of cancer prevention and implement evidence-based policies to minimize the incidence and death from preventable causes of cancer. It is also unacceptable that many benefits of scientific discoveries and clinical breakthroughs are not reaching all segments of our U.S. population. The stark reality is that individuals belonging to racial and ethnic minorities and other medically underserved populations, such as those living in rural areas or those belonging to sexual and gender minorities, continue to shoulder a disproportionate burden of cancer. You will hear more about these challenges from Dr. John Carpin. Moving forward, we must ensure that everyone benefits from the groundbreaking progress against cancer if we are able to achieve the goal of health equity for all. It is clear medical research has and will continue to spur progress against cancer. If we seize the opportunities to drive research forward, we can stimulate additional breakthroughs that will indeed save lives. As a nation that thrives on scientific innovation and technological advances, we must make medical research a priority. A major goal of the AACR Annual Cancer Progress Report is to serve as a call to action to Congress, the administration, and the public to strongly encourage funding for medical research through the NIH. With the right resources, we can accelerate the pace at which we develop new strategies to prevent, detect, diagnose, and treat cancer, and ultimately continue our pursuit to eradicate the disease. Most importantly, these actions will ensure that we continue to find cures for cancer for the benefit of all patients and their loved ones. Thank you so much for your attention. It is now my honor and privilege to introduce to you Dr. John Carpin, who will highlight the areas of the report that underscore the urgent need to reduce cancer disparities and achieve health equity for all people, regardless of race, ethnicity, sexual orientation, socioeconomic status, or the communities in which they live. Dr. Carpin is extremely well qualified to do this, as he is a world-renowned expert in cancer genomics and a pioneer in investigating the biological determinants of cancer disparities. He also previously chaired the AACR Cancer Disparities Progress Report 2020 Steering Committee, as well as the AACR Minorities in Cancer Research Council. And just last year, Dr. Carpin was named chair of the National Cancer Advisory Board, a body that advises and assists the director of the National Cancer Institute. In addition, Dr. Carpin is a professor and chair of the Department of Translational Genomics, director of the Institute for Translational Genomics at USC Keck School of Medicine, and associate director for basic science at the USC Norris Comprehensive Cancer Center. Please welcome Dr. Carpin.
Thank you so much. What an honor to be here today, and what a beautiful day here in Washington, D.C. I'd like to thank Dr. Foti and Dr. Cousins and the AACR for their dedication and longstanding commitment, support, and efforts towards ending cancer disparities. And of course, for everyone who's here today, both in person and virtually, as we roll out the progress report. As Dr. Cousins stated, there's been considerable progress in our abilities to fight cancer. Since the declaration of the war on cancer in 1971, there's been approximately a 26% reduction in cancer mortality rates. More specifically, we've seen a 32% reduction in cancer mortality rates in the U.S. between 1991 and 2019. Appropriately, we've also seen a significant increase in 5-year survival rates for all cancers combined, increasing from 49% in the mid-1970s to nearly 70% from 2011 to 2017. However, despite these improvements, disparities in cancer incidence and death rates persist among underrepresented minorities and the medically underserved communities here in our country. Central to these disparities are socioeconomic and environmental issues related to inequalities and access to quality care, particularly as we consider that many individuals in underserved communities seek care, including cancer care, at safety net hospitals. Community clinics and safety net hospitals rely on federal and local funding to provide uncompensated care for patients who don't have insurance or have limited coverage. These facilities are also the least likely to have resources and infrastructure in place to enable clinical trials for patients that need them the most. As described in this report, clinical trial participation these participants experience better outcomes compared to those who do not or cannot participate in clinical trials. Yet more than 75% of patients with cancer either do not have a trial available for their specific disease, or the eligibility criteria are too strict for their participation. There are other barriers to clinical trial participation that increase cancer disparities as well. That might include the fact that many patients that are not being asked to join trials. Patients have consistent and persistent mistrust in medical research. There are dependent needs as well as costs associated with participation, things like driving to a cancer center or even situations related to parking. So increasing representation in clinical trials for racial and ethnic minority populations, as well as others that are medically underserved, is a key step in addressing the underlying structural injustices that prevent equitable access to quality cancer treatment. As described in the call to action, the Diverse Trials Act and the DEPICT Act, which provide the FDA the authority to issue and enforce requirements for diverse representation in clinical trials, permit trial sponsors to reimburse patients for transportation costs, increase the use of telemedicine, and improve data collection. Related to the adverse, preventable cancer outcomes that we see in medically underserved communities, diversity in the cancer research and care workforce does not reflect the general U.S. population. Increasing diversity within the cancer research and care force increases the quality of care, improves patient satisfaction for medically underserved groups, and encourages clinical trials enrollment. As stated in the report, increasing funding to support grants for early career scientists, as well as early and universal access to STEM education and intentional mentorship have been shown to increase diversity in the cancer research and care workforce. These are just some of the policy recommendations contained in the policy chapter and the call to action of the report, which would greatly reduce these disparities and improve care for all. In addition, robust, sustained, and predictable funding for the NCI and the NIH will provide the support needed to drive scientific innovation, improve health outcomes, and ultimately reduce cancer disparities. So thank you very much for your attention and your support for this report. Thank you.
Thank you, Dr. Carpton. It is now my extreme pleasure to introduce to you Dr. Anna Barker, who will discuss the importance of patients' voice in cancer research. Dr. Barker is Chief Strategy Officer at the Ellison Institute for Translational Medicine and Distinguished Visiting Fellow and Professor at Arizona State University School of Life Sciences. Dr. Barker previously served as the Principal Deputy Director of the National Cancer Institute and Deputy Director for Strategic Scientific Initiatives. In 2020, Dr. Barker began her tenure as a member of the National Cancer Advisory Board. Dr. Barker also serves as chair of the AACR Scientist Survivor Program since its inception 25 years ago. And we are indebted to her for creating a program that builds productive relationships, positively changes the lives of those affected by cancer, and constructively impacts the work of cancer researchers. Please welcome Dr. Barker.
Thank you, Dr. Cousins, and welcome everyone. Welcome to everyone online. It's a great day whenever we actually release this report. I hope that everyone in Congress is watching and that they're opening it up today, especially the last couple of pages, which speak to the budget for the Cancer Institute. As a member of the National Cancer Advisory Board, I can't say more than that, but make sure you read those pages for sure. My job today is to talk a bit about this relationship between cancer research and cancer advocacy. And what I have to say is it has a history that is just remarkable. It started actually in the early 90s when patients actually discovered that things were happening in science that they, one, should know about, and two, should do something about. And so it started very early, in the early 90s, and what that led to was actually a march on Washington in 1998. Depending on how you count, 250,000 people showed up in Washington that day to say, no more cancer. We're done with this. We want more out of Congress. We want more out of science. And we're willing to pitch in and help. We'll do anything possible to make sure that this happens. After that, the AACR, we were first, actually, in terms of scientifically figuring out that the future belonged to this relationship between cancer scientists and cancer advocates. If we didn't have that relationship, one, as someone who has lost my entire family to cancer, you don't understand cancer until you actually see cancer or you experience cancer. It's never what you think it's going to be, and every cancer patient that's diagnosed, it's like a bolt of lightning. I don't care what you know and who you are, it's still that bolt of lightning, and you don't believe it's going to happen until it does. So we set ourselves on a path to sort of understand and build this relationship between scientists and advocates. And we set up a program called, I didn't know it would last for 25 years, to be honest. I thought we would do this for a few years, but it became very popular. So we're in our 25th year. It started as part of the March on Washington. I mean, so we decided this went so well, and the AACR had such a presence there, and we wrote a report for Congress out of that March on Washington that said essentially what I've just said to you. It's going to depend on this relationship ultimately between science and advocacy to really make the progress that we need. So we set up that program, and it's been ongoing now for 25 years. We have trained probably well over 1,000 advocates, but that doesn't mean 1,000 advocates have been trained. These are heads of organizations who have gone off and trained hundreds of thousands of other advocates. And guess what? Today we have a population of highly educated advocates. And I think in some situations I've found sitting in a room of really good scientists and really good advocates, I can ask a question, and I'm careful that I ask the scientist before I ask the advocate, because sometimes they know more about the question than the scientist that I'm actually addressing the question to. And why is that? Because they became educated in what science is, what's the rate of progress, and mostly, how does it relate to me and the disease that I have? Today, for example, if you look back on what Dr. Cousins talked about in terms of the progress that we've made, I have to say, I look back to the first time we did this report in 2011. I couldn't have predicted where we'd be in lung cancer today. Does everybody understand? We had no drugs for lung cancer. We had no drugs for multiple myeloma. And as you heard from Dr. Cousins, FDA, I think they're really busy over there. They're approving drugs at a rate that we've never seen before. So this whole process, this whole movement has changed the world, hasn't it? It's changed the world, and it will continue to change the world. And why is that? Because less than 5 years ago now, and the pandemic made everything go faster or slower, depending on where you were, or what you were doing. But these years have finally awakened all of us to the fact that patients know a lot about their disease. They know a lot about the drugs they're taking. And oh, by the way, if you collect that evidence, you can actually look into that evidence with new artificial intelligence and find things that we would never have found otherwise. Were you guys surprised by that? Not so much, right? So real-world evidence and real-world data is here. It's here to stay. And the pharmaceutical companies are using it now to get their drugs approved. And so it's the culmination of this relationship that's made all of this work so well. Now, if I look ahead, I think, what are we going to do next? The one thing we have to do is what Dr. Carpenter said. If you live in Kentucky or Appalachia or on the border between Mexico and the United States or in a poor area of a poor city, you may get more cancer because you don't get diagnosed early. You may not do as well if you do get cancer because you don't have access. If we don't change that, all the technology in the world is not going to matter. The president's challenged us with reducing this burden of cancer by 2025. That means the number one thing that has to happen is this country needs to clean up its act in terms of access to care. And for cancer especially, cancer is expensive. It hurts families. It doesn't just hurt the person who gets the cancer, I can tell you that right now. So we have to fix that problem, and we have to commit scientists and clinicians who are working on the front lines, and those that are actually advocating have to take this on and do something about it. Right, John?
Absolutely.
So we can do this, and there's no reason we can't do this. We're talking about sending people to Mars. Let's just solve this problem first. But by the way, I love Elon Musk. I hope he gets into cancer soon, and we'll probably put somebody on the Mars at the same time. So the second thing I think that I've learned in the pandemic is that coming back to the president's challenge to us, if you look at Dr. Cousins' graph over how we've done overall in cancer over these last 20 plus years, what you'll see is that those changes have been pretty incremental. And I heard Ned Sharpless, who was our former NCI director, give this talk the other day on how hard it's going to be to meet the president's goal for the moonshot. It's going to be hard. That's a big number. It may not sound like much, 25, it sounds like a long way off, and it sounds like not such a big number. But it is a big number. And so it means that we're going to have to work smarter, faster. I mean, we're going to have, as Andy Grove used to say, more knowledge turns in cancer science and more knowledge turns in the kinds of ways that scientists and advocates work together. So I'm really optimistic. I think it's the best of times. We're awash in data, big data. We are really early in actually organizing that data and interrogating that data. And I will say this, a lot of what's going to help us there is what advocates are doing. They are organizing their groups around genes. Do you believe this? The lung cancer group has an ROS group. They have an EGFR group. I'm serious. And they know that biology like the back of their hand. So what's going to happen here, I think, is that these relationships are going to help us with those knowledge turns. Because if people know what to do when they talk to their clinician and the clinician is listening, those people are going to get the kind of care they need. And that's not always the case. So the other thing I think people know me, they know I'm going to say this, but we in oncology and cancer research have done really well. I mean, I had an opportunity, I was at the Cancer Institute, to lead a lot of really super projects that made a big difference, like the Cancer Genome Atlas. But where we are depends that cancer biology open its arms to physicists, mathematicians, engineers. We are three-dimensional beings. We live in time and space, and we're not going to get much beyond analyzing all the data we have and doing with it what will most benefit patients until we welcome those folks in. Last but not least, I want to congratulate our educated survivors who are here today. I mean, it's an amazing group. It always is. When we did this report first in 2011, we said there will always be individuals in these reports who have benefited from the research. And we've done that every single year, and every single year they are the stars, and they are the stars. So those of you that know me believe that any person in this room can change the world. If you can do anything. If you have a great idea, you know what the problem is, you have a great idea, what do I say? Start. You know how many great ideas never start, never get off the starting blocks, and then do the work. And that's what patient advocates have brought to this equation. They do the work, just like the scientists sitting in this room and out there online. So let's change the world and look forward to the next progress report. And by the way, this is very hard to do these reports. So I congratulate everyone who's ever done them. I know how hard they are to do. And we look forward to this one and that we're going to see in whatever year this is, 2023. So thank you all very much.
Thank you, Hannah. Now, it is my absolute great pleasure to introduce to you Alexandra Vitale and Johnny Bergstrom, who you saw in the video earlier and are joining us on the panel today. Alexandra is 31 years old and lives in Townsend, Delaware, where she works for Schneider Intermodal as an account development director. When Alexandra was just 5, she was diagnosed with von Hippel-Lindau disease, a chronic condition characterized by the formation of benign tumors and cancers in different parts of her body. Indeed, over the course of her lifetime, Alexandra has developed several benign and cancerous tumors that have required major surgeries, among other treatments. Throughout her journey with cancer, Alexandra has had an incredible support system with her family and her partner of 3 years, Shelby Smith. We are so grateful to Alexandra for being here today to share her story. Please welcome Alexandra to the podium. Thank you.
Good afternoon, everyone. My name is Alexandra Vitale. I am 31 years old, and I'm living with von Hippel-Lindau syndrome, also known as VHL. As Dr. Cousins told us, VHL is a rare genetic disorder that causes both benign and cancerous tumors in various parts of the body. Typically, VHL tumors can be found in the adrenal glands, kidneys, pancreas, eyes, brain, and along the spinal cord. And if I've named it, I've had them. Normally with VHL patients, the typical course is to perform MRIs or CAT scans every 3 months to a year, depending on doctor's recommendations. The goal is to identify and watch the growth of these tumors, with 3 centimeters being the threshold that we don't want them to get to. My understanding is once these tumors get to 3 centimeters, they are more likely to become aggressive and metastasize. Once a tumor is determined to be tracking at 3 centimeters, most of the time the next step is to undergo surgery to remove the tumor. My personal journey with VHL has been a long one, spanning 25 plus years. I was first diagnosed at the age of 5 when I needed to undergo my first surgery due to a tumor on my optic nerve, causing me to lose my sight and my actual eye. From then on, it seemed as if the tumors just never stopped coming. I have had pheochromocytomas on my adrenal glands, causing me to need an adrenalectomy. I have had neuroendocrine tumors in my pancreas, which have caused me to undergo a Whipple procedure. That was my least favorite surgery. I've had a craniotomy due to a tumor on my cerebellum, and I have also had a partial nephrectomy due to being diagnosed with renal cell carcinoma. Sprinkle in various procedures, and that is what my life looked like between the ages of 5 and 26. Surgeries every couple of years. Unfortunately, for a bulk of the VHL community, that is what a normal life would look like. At least that's how it was up until the introduction of PT2977, also known as belzutifan. It has a real name since being FDA approved just last year of Welireg. I was lucky enough to be first introduced to this drug back in 2018 when I was asked to be part of a clinical trial, and truthfully, I haven't looked back since. I know it sounds a bit cliche to say that my life changed drastically once starting this med, but it's really no understatement. Prior to having access to this medicine, I went into every scan and every doctor's appointment apprehensive and praying not to hear the words growth or cancer, for fear that my next surgery was just around the corner. And I could tell you from experience that no matter how prepared or strong you think you are, you're never ready to walk into an appointment and have a doctor tell you that you have cancer. Not that I ever thought I would be ready, but I definitely wasn't at the age of 25. Hearing those words just drains everything out of you until you're finally numb. But then this miracle drug came along, and that's what my family and I call it. And since I started in 2018, my renal cell carcinoma tumors and my neuroendocrine tumors have either remained stable or have shrunk substantially. In my latest scans, my kidney tumors measured less than 1 centimeter, shrinking from 3 centimeters in 2018. All of these words or phrases are words that I never thought I would ever hear. Shrinking, stable, in my entire life. And then belzutifan came along. Thanks to this drug, I feel like I feel like I could be a normal 30-year-old who's not worried about dying every second. I feel as if my clock has been reset, and I have a chance at a full life that's not driven by when my next surgery is. Investing time and energy into therapies such as belzutifan will eventually lead to the curing of all cancer. And if there's anything I've learned in my 31 years, it's that cancer does not discriminate, and everyone's life in some way will be touched by cancer. So my question is, why wait? The time is now to continue pushing forward in cancer research. Everyone deserves to find hope just as I have, and cancer research is the first step. I would finally like to say thank you to my amazing team at University of Penn. Thank you to the VHL Alliance for bringing this small community of VHL warriors together to support one another. And finally, just thank you to my family who never lose hope and keeps me strong. The best is yet to come. Thank you all.
Thank you, Alexandra. Now it is my pleasure to introduce to you, Doctor. You've gotten a doctor. You're a doctor all the day. Johnny Borgstrom, who is from Big Cabin, Oklahoma. Johnny is 70 years young and has been living a retired life on his farm after working for 36 years at the United Parcel Services. Johnny's cancer journey took him from noticing a small bump on his head in October of 2017 to a diagnosis of metastatic melanoma in early 2018. Being from a rural area, Johnny had to advocate for himself to receive the best possible care for his cancer, and we are looking forward to hearing from him about his remarkable cancer journey. Johnny is here today with his wife, Deborah, and his granddaughter, Cheyenne. Johnny, we're grateful that you shared your personal experience with us for the Cancer Progress Report, and we are delighted that you are here today.
This for a country boy is kind of strange. I do live in a small community. It's a little town called Big Cabin, Oklahoma. Population about 150 to 180 people. Very few, you know. I live with my wife for almost 51 years. We've been married. I have 5 grandkids. I have 1 great grand dog. I have 2 daughters, Tammy and Shanista. You know, like Johnny and Debbie, you know, we thought we would go with Tammy, and then somebody said we had Shanista. Where did you come up with that? So that was her. But I was diagnosed with aggressive melanoma cancer January 10th of 2018. After 3 surgeries in Tulsa, which is about 60 miles away, I called my doctor. He walked on water. Because he did the surgery, I had 3 back-to-back surgeries to remove the cancer from my head and through my neck. And he did a great job. Meanwhile, they did a X-ray, and the melanoma had leaked into my lungs. So we didn't really feel comfortable being there. So we heard about MD Anderson, you know, a great medical hospital for cancer. You know, and the one thing I liked about their symbol was cancer slash. In other words, we want to eradicate cancer. We don't want you to keep cancer. So that's kind of where my story began. We went there for a second opinion, and we heard that MD Anderson was a good place. So my daughter made a call. It was in Houston, Texas. It is a 12-hour drive one way for us. So she called, and she made an appointment, and we saw him about 2 weeks. I met with a doctor on April the 4th of 2018. His name was Dr. DeBobby. They did a lot of tests. They did CTs. They did MRIs. They did find that it had leaked into my lungs. So they did a lung biopsy. They found out that I had 2 on the top. I had 2 on the bottom. The centimeters was like 12, 7, 3, and 5, which I don't know anything about centimeters, but I figured it was pretty good. And Dr. Tababi said, that's where I want it. And I looked at him like, you want it in my lungs? And he said, that's where I want it. I said, okay. I trusted him. So on April the 4th, I met with him. And like I said, they did several tests of MRIs, and they saw where it had leaked into. And they was going to do immunotherapy on me twice a month, double dosing twice a month. But on the 24th of April, there was a new trial medicine came available. In fact, he said it was into Australia for 2 weeks, and he asked if I would do it. He said it was a double-blind study, and I said, what is a double-blind study? I have no idea what a double-blind study is.
You do now.
I do now. He explained it out to me. He said, you may never know whether you're on the medicine or not. I will not know. He said there's only one person in this hospital will know that you're on that medicine, on the experimental trial medicine. You know, but it came available to me. So I told him, I said, yeah, let's do it. He said, do you want to think about it? I go, no. I made a statement. If it helped me and a child and another adult, you study me. If I don't make it, it's okay. Well, I'm fine with that. But if you learn from me to help others, then let's do it. And he kind of looked at me kind of funny. He said, I've never ever heard a patient of mine say that, you know. So we went about it, and I also told him that my God's bigger than what's the matter, and we went on. So the research team, they needed more tissue. So they did another biopsy to get more tissue. So I went through a second biopsy. The first trial started on June the 4th of 2018 for my treatment. It was for 2 years. Within the 12 treatments, the spots on all my lungs were shrinking. They were disappearing. To as much as Dr. Bobby said that I could pull you off of it right now. But he said, since you did a 2-year study, would you continue the study? And I said, yes, I will. So we continued the study, and on May the 4th of 2020, the cancer had disappeared. Now, MD Anderson don't say you're cancer-free. MD Anderson said it's in remission. So they did scans every 12 weeks. First it was 3 months, and then went to 12 weeks and on and on. So I was doing scans, to make sure the cancer hasn't came back. On May the 4th of 2020, I had no sign of cancer at all. I would like to say that to people that are afraid of trial studies, don't be afraid. I had 3 great research nurses that took care of me. If I had a question, I would just text them or call them. They would give it to the doctor and say, yes, you can do this, you cannot do this, da-da-da. And they said yes. I had real good research nurses that took real good care of me. So what I say, don't be afraid. I needed scans every 12 weeks to make sure, that the cancer hadn't come back. One time, Dr. Bobby walked in and he said, thank you. I said, what are you telling me thank you? I'm coming from a doctor. I said, what are you telling me thank you? He said, by you doing the study. When I first signed up for the study, there was 8. My research had 8 of us. I was one that signed up for it. Then the next year, there was about 30. 30 got on it. He said, I just want to tell you thank you. He said, by us studying you, we've been able to put 700 more people on the medicine, and it is being successful. So I thought that was coming from a doctor. It made me really feel good. So what I'd like to say today, I had to thank my God and my family. My family was my biggest support. They thought from Oklahoma we'd come to Texas, and they thought we was, I don't know. We come down there, we was laughing and we was carrying on, and we just really staying positive. So I'd like to thank God, and I'd like to thank my family, the doctors, the researchers, the scientists that made this available for me. Thank you all.
Thank you so much to both of you, as well as to Dr. Barker and Dr. Carpton. We're now going to turn this over to a Q&A session for all of us here at the podium. So if you have questions, we would be very pleased to interact with you and answer them. And beyond that, thank you so very much for participating in this event with us today. It is truly our pleasure and truly my honor to be here to talk to you and to represent the AACR for this progress report. Thank you.
Yes, I'm just curious, did you see any impact of the COVID pandemic on some of the numbers?
I'll stand up so I can see you. The AACR put out a report last year detailing the impact of the COVID pandemic on patients with cancer, most notably. And what the results of the report revealed is that there was a very significant decline in early detection screening and overall attention to patient health where cancer diagnosis would have happened. And so the prediction that comes out of that awareness is that there will be an increased incidence of late-stage cancer that will start showing up this year, next year. The pandemic absolutely had an impact on healthcare, and very clearly individuals that are at risk for long-term chronic diseases like malignancies.
I think, and just to add, I think we also learned from it, right? I think the one thing we learned is if you really want to do something, you can, right? We think about Operation Warp Speed and the convergence of all the, industry, the government, right, the community, right, to say this is something we have to address and we have to address it now. And so we're hoping we see, similar efforts and initiatives moving forward in cancer. So we learned a lot from the pandemic.
And just to pile on a little bit, I think Johnny's comment is appropriate here. I mean, we learned how to do clinical trials and do them much more quickly and actually pay attention to some of the things we've talked about up here. And the second thing I think was remarkable is I've never seen that level of global scientific collaboration at that scale come together so quickly. I think it puts the pressure on cancer. So we can do faster, we can do more, and probably will. I mean, I hope we will.
So I have some questions for Johnny and Alexandra. Johnny, you traveled quite a distance to get to MD Anderson in Houston to receive care and enroll in your clinical trial. Can you tell us about the obstacles for cancer detection and treatment for patients in rural areas?
Well, like I said, I live in a small community, and the largest hospital is 60 miles away, either Joplin or Tulsa. Somebody may ask why I drove 12 hours to do treatment, 28 days in a row, every 28 days I did treatment. They were family. I can't say any more to that. They were family. They took care of me a lot. And you was talking about through the COVA. Yes, I had to go there by myself.
Yeah.
When I rang the golden bell, I didn't have my family with me. But all my infusion nurses for that 4 years were there and helped me ring the bell and took the pictures. So it made a big difference.
Wow. I hadn't thought about that aspect of COVID on the cancer journey. Alex, your message of hope is apparent in your story. Can you share with us what funding for cancer research means to you?
For myself and for other cancer survivors and fighters, this funding is, I think I said it in my speech, it's a reset on life. It gives us a reason to look forward to each and every day. I went through the first 26 years of my life literally thinking that I was going to go into every appointment just hearing a new tumor, a new cancer is going to pop up. So being able to take part in a clinical trial such as this, it's life-changing. And quite honestly, I'm not the only one who deserves it. Everyone deserves a chance at a drug or at some sort of therapy that just gives them a new shot at life.
Johnny, with regards to your participation in the clinical trial, are there things about the trial process that you identified that you would like changed? How could the trial and your participation in the trial have been more supportive or perhaps progressed in a more supportive way for you and your family?
Well, I was, for never having cancer or never really having any cancer history in my family, I thought they moved fast enough, to me, because mine was aggressive, and I knew that I only had probably a year to live. And I just felt so comfortable by the research being there and the way they performed it and did everything to make sure that I was cured. I wouldn't have thought in 12 months my cancer was gone as fast as he was moving, because it was moving so fast that I wouldn't have made it. So I hope I answered your question.
Yeah, indeed. And Alexandra, for you, can you speak a bit to just your support network? Personally, your family, the caregivers that have helped you along the way, but also the support group and advocates that you've interacted with more on the clinical side?
Absolutely. I will be the first one to say that I have the best support system in the world. That includes my family, and it's mainly made up of my family and close friends, but ultimately I have a full team at University of Penn, and when I tell you that through my entire journey of VHL, they are my family as well now. Johnny spoke to it. You begin texting with doctors, your research nurses, and anytime you need them, they are there. You don't feel like a number. You feel like they want you to get better. You feel like your progress is their progress, and it's unbelievable. I will tell each and every person that I meet, if they have anything going on, go to University of Penn, because they're like family at this point. So I hope that answers it, but it's you feel valued. You feel like a real human when you're working with these doctors and nurses.
That's great. And from both of you, what message would you give to members of Congress about the importance of sustained investment in basic research and the cancer continuum to bring discoveries to the clinic so that more individuals like the two of you can benefit and live long, healthy, happy lives?
Me? We cannot slow down. You've heard these amazing speeches today. We cannot let up. I like to say that the best is yet to come, and for me that means in my personal life, but for looking forward in cancer research and quite honestly the curing of cancer, we cannot slow down. There are amazing individuals out there that their lives are just being pummeled by this C word, and we can make the difference. And I'm not smart enough to make the difference, but I know that there are plenty others out there that can. So just pedal to the metal, please.
I'd say to Congress, we need this for us to survive, for other people to survive. The cancer research needs the money and the billing to be able to afford it. I'm in a rural area that rural people don't have that opportunity. Please do the funding so that the researchers can get the medicine out to them, so the hospital's 60 miles away from a rural area that they can have a place to go to cure cancer. That's what I would say to them.
So I wanted to say that first of all, thank you so much for sharing your story. What's fascinating about the stories of these survivors is that both of them were treated at academic health centers, and we know that only 15% of the cancer care is being taken care of in academic health centers. So we clearly need to get the message and get the training and expand into the community to make sure that others are benefit from this. And it was wonderful that Johnny could actually relocate, his care so far away from home. One of the things that I remembered when Dr. Barker was talking about the report that came out from the March in the late 1990s. If you recall, it was the March Research Task Force report that was prepared by a team of scientists and led by Dr. Philip Sharp, who's the Nobel laureate. And that group at that time indicated that we needed $15 billion a year to be able to, you remember this, Dr. Barker, $15 billion a year to be able to make strides against cancer. That was in the late 90s. We're happy with the funding we have now, and we are very appreciative of our legislators. But more work still needs to be done, obviously, and it's expensive to do research, and it will be very expensive to try to get the top therapeutics into the community. So I wondered if any of our scientists could comment on how can we change this picture. Right now, only 5% of the patients are on, adult patients are on clinical trials. How can we get to what was recommended in that report, which was 15%, I think, as I recall? And what is needed to infuse not only more monies, but have more scientists and physicians helping to correct this situation?
I'll start because I actually had the task of really writing that report, so I remember putting those numbers down, and now I look back and think, oh, what were we thinking then? But I honestly think that it's a complex problem, and I hate people who say that, but it's a complex problem because, if you look at what it takes to do a clinical trial, and as Johnny pointed out, the kind of trial he did. These are the trials that have to be done to determine if something is really going to work. So a lot of patients are just wary about going on a trial. And Dr. Carpenter mentioned another reason, that's trust. But I think maybe the biggest issue is the trial structure itself. And so the pharma companies, you may know this, you've seen these data, it takes about $2 billion to develop a drug in this country, and it takes about 15 years. We have to change that, and we can change that. We've proven that with innovative trials today, one of which I'm involved with is called the I-SPY 2 trial. Dr. Herbst was involved in a trial for lung cancer, similar kind of experience. There are ways to really speed up this process, and we should take those ways and we should ask the pharma companies to change their policies, change their approaches, and get on board and do these things faster, quicker for patients. And they can do this. It can't always be about the money.
Yeah, and I think with that, this whole concept of democratizing care, being able to get the care out into the community so Johnny could have gotten the exact same care, right? Much closer to home, closer to the support system. I think that we're going to have to develop new models. I've been guilty of putting my foot in my mouth before. I just think that what worked in 1971 may not necessarily be what's going to work in 2022. And there's always fear, right? There's fear to break the system down because it has worked, right? We've made progress. But if we really want to advance, right, at the level at which we've heard our president challenge us to, I really do think that we're going to have to consider new models of distributing care, quality care, and moving it out from these centers and get it closer and closer to the community. I don't know what that looks like yet, but I think that we have to bring all these brilliant minds together and figure it out, or I just don't think that we'll get there.
I think you're right.
I'm going to add just a little bit to that, in that it's not just the end of the pipeline where care is delivered that we need to focus and make major investments. We also need to think about how to empower and enrich and excite young people to stay within the sciences, to participate in basic science education in middle school, in high school, to pursue STEM education at the graduate level, and then to go into fields of biomedical research and biomedicine and care. If we forget about supporting the early pipeline, we'll get these drugs out there, but then we won't have brilliant minds to keep fueling the pipeline and deliver the care. And so it's the cancer continuum that needs to be absolutely invested in at all stages of the pipeline.
So we have three physician scientists in the room, in the audience here, Dr. Herbst, Dr. Stewart, Dr. Oman. I wonder if any of them or all of them would have some comments to add to this discussion. I think coming around with a microphone. Would you mind commenting on the challenges, please?
I'd be pleased to comment. I'm Gil Oman from University of Michigan, Rogel Cancer Center. Congratulations to both of you, Alexandra and Johnny. It takes massive commitment from the patients and their families, and not just from the doctors and nurses and everybody else. But your cases illustrate another big part of the challenge. When we talk about cancers, there are so many different kinds of cancers. It's quite hard, even in the major center, to have an expert for everything, and to take it out, as we would love to do, to the doctors and hospitals close to where people are. It's going to be, in the case of unusual cancers like yours, probably very important that you can get access to the place where they've seen quite a few of these cases that most physicians will never see one. So this is a big part about cancers in the plural. Part of the research of the last many years has been to show that the mechanisms, the reasons for the growth and proliferation of cancers are very many. And the diagnoses have to be targeted to specific pathways. And then the drugs have to be to the different pathways. So this is what now we call precision medicine, precision oncology. That's still in the hopeful mode, but it's coming. So I think it's up to us to work closely with community people and patients, families, and everybody has to realize we've got a big challenge, and there's plenty of progress, and there's lots more to be done, but it won't just happen because we'd like it to be there. We have to work at it.
Thank you, Dr. Oman. Dr. Stewart, you're a surgical oncologist and a cancer center director in Louisiana. Could you provide a perspective, please?
Sure. Thank you for the opportunity to attend, and thank you, everyone, for your comments. Johnny, I was a melanoma doc in my earlier days, and I gave people hydrocyle-2. And then we subsequently moved up to checkpoint inhibitors. So thank you for your participation in helping us move forward. Alexandra, we had a VHL population when I was at the NCI, so I understand your pathway, and thank you so much for your participation. Now, I think that the crux of the issue is that we will not improve outcomes in cancer until we address the disparities that exist within cancer, and I think Dr. Carpin nicely relayed what those differences are. It's going to take a concerted effort. It's going to also take the legislature to set aside appropriations so that we can specifically study not just disparities in cancer, but also disparities in a variety of diseases. And I think the time is now. As my president told me when I met with him in Baton Rouge a few weeks ago, he said, listen, man, people are dying. Let's go. Okay, so the time is now, and I'd like to echo the urgency of the issue.
Thank you, Dr. Stewart. Dr. Herbst?
Yes, hello. I'm Roy Herbst. I'm Deputy Director at the Yale Cancer Center, and I work mostly in lung cancer and immunotherapy. This has just been so inspiring to me to hear your stories. I was at MD Anderson for quite some time myself, so I know what your experience can be. We have to take what we can discover from science. The AACR is dedicated to science and bringing that science to you, the patients. And it's wonderful to see that that's happening, but we have to do more of that. We need the best science. We need discovery science. Van Hippel-Lindau disease, we understand the mechanism of that. And by understanding the mechanism, a drug could be made. Melanoma, we understand that immune system can help with treating it. That's how these drugs come together. So that's step one. Then step two is the clinical trials. We need more clinical trials. They need to be at the point of care. And it would be great if there were more in the community, and that's what we're working on. And how do we do that? These trials work. You got better care because you are in clinical trials. What we need to do is we need to try to get those trials out to all populations. It's a matter of access. Many people don't have access to the cancer centers. We need to provide transportation, as we heard today, support. We also need to build trust. You know, one of the things we're doing in the AACR, working closely with Bristol Myers and other foundations, is we're trying to develop investigators that represent the community, train them to do clinical trials, because we have to get out there and build trust, treat patients as early as possible, do screening. So it's just wonderful to see this all coming together. We are making a difference, and I heard Joe Biden last Monday, and I think we can get close to that. We can aspire to it, but the only way we're going to do that is with access, with more science, with more trials, more trust, and more teamwork and collaboration. So I'm just thrilled to be here today.
Thank you so much, Dr. Herbst. Well, you know, we heard a little earlier about immunotherapy, and the report shows that we went in only 6 years from 5 cancers that are being treated with immunotherapy to now 18. And it's fabulous that this is happening, and it's a transformation. AACR had an immunologist as one of its founders in 1907. So we're thrilled that immunotherapy is coming into the picture. I want to also say that we're very, very proud that we have so many scholars, the brain trust of the field in the AACR, and at the time of our 115th anniversary, we are celebrating progress, but obviously there's much more work that needs to be done. And trust in science. We have a new task force on trust in science, and our population needs to understand that scientists are helping and that they should believe in science and believe in clinical trials. So thank you very much for focusing on that. I believe we're at time. One more question in the back.
Hi, yes, we have a question from somebody on the line
Yes.
who asks, can you tell us how or if telemedicine during the pandemic has impacted access to clinical trials?
Who wants to take that on?
Could you repeat the question?
Please repeat the question.
Can you tell us how or if telemedicine during the pandemic has impacted access to clinical trials?
John?
We should ask one of our,
Right.
of our MDs. Yeah.
Dr. Herbst, we'll take that question. Thank you.
You know, no one would say COVID's a good thing, but the access to telemedicine, I believe, has helped clinical trials.
Yeah.
Why? Because patients can get access sooner, especially from a distance. You know, Oklahoma, 12 hours from Texas. You could do a televisit, and when you get that first biopsy where you need that material, we heard from Gil, the precision medicine, then we can make sure that it's tested in the right way so that we know if you might be accessible for the trial. You know, of course, for medicine, you have to come in and see the patient, see the doctor, but there are some screening visits that can be done by video. So I think it's increased awareness, it's increased access, and then, of course, for screening trials, so much easier to do this by video. So no substitute for coming to the hospital, but I think it's been a very big advance. As long as we use it wisely, it's going to help us in the future.
Thank you, Dr. Herbst. Are there other questions from our virtual audience?
Yes, we have. I'm so sorry. We have one other question asking about the future of cell-based therapies.
Yeah. Yes. Well, I think what we know is that there have been incredible advancements in pediatric cancer, utilizing, for instance, the CAR T technologies, tuning a patient's own immune cells against their specific cancer. And I know that there are tremendous initiatives underway to advance this against more solid tumors, both in peds as well as in adults. So it's an incredibly active area of research, utilizing various immune cells, the T cells, and new studies looking at NK cell targeted CAR Ts. So it's advancing. So this whole concept, it's just another sort of point in the game as we think about immunotherapies, right? Using our own immune system to fight the cancer.
Just adding a little bit to that, it's interesting. I guess I go back at NCI and look all the way back to when people really at the NCI started working on CAR T cells, and there was not a lot of thought that we would ever see this scale, and now we are. And so of all the things that we've done, I think in immunotherapy, in terms of individualizing therapy, this is the one that has the most promise. But there are issues in terms of how you scale these therapies. They're expensive, and the NCI is now looking at approaches to scale some of this science, and hopeful.
So before we adjourn, I just wanted to tell everyone that today in New York, Dr. Jill Biden is at one of our cancer centers in the United States to discuss the focus of the president on cancer research. And we're so proud that he has pushed hard to reignite the Cancer Moonshot, which will really focus on all of cancer research, but also cancer prevention, interception, and early detection, of course. And we're very happy. we will do all we can as an organization to help the administration to move forward those advances. We've already heard today that at least 40% of the cancers are preventable. And we have to really work on communicating to the public the importance of changing habits, lifestyle factors, and so on, and helping all populations, as has been discussed today. So I guess we're at time. Thank you very much, everyone, for your attention. We really appreciate your input. Goodbye.